scenario today. We have 5 different scenes set up. We have people from town boards, we have state representatives, and we have media people here from Wausau, Merrill, Antigo, Rhinelander, Weston, all over north central Wisconsin. So it's a tribute to you that you could show up today. We're fortunate that we have a great day. It's a great day to be a firefighter. Just wanted to let you know this isn't just one department because we're holding this in Merrill. Merrill is one of the departments holding this fire ops today, along with Antigo, Wausau, Weston, and Rhinelander. The departments in the north central Wisconsin area got together with MTC and came up with the idea to do a fire ops like we've done on the state level in Madison, and we also did one in Marshfield last year. We're fortunate in Merrill that we have MTC, this fire training facility that we in Merrill can train all the time, along with others that come up here for classes. You're fortunate today to be able to utilize this facility as well. Before we actually get into what you're going to do today and explain that to you, we wanted to show you what EMS people do or paramedics do in our area. We wanted to show you exactly what firefighters do when they're on the ambulance. The scenario that we picked for you today is a PNB, and what PNB means is pulseless non-breather. Basically dead, okay? We get a lot of calls like that for people that are like that. Time, seconds count, especially with people like that. So what I'm gonna do is I got 3 of our paramedics from Merrill. I'm gonna pull this table up, you can see their trained mannequin. They're gonna come up and they're gonna go through a full code, and code is a PNB, somebody that's not breathing, somebody that doesn't have a pulse. They're gonna show you exactly what they would do when they arrive on scene and how they try to bring that person back to life. I also have Dr. Sullivan here. He's from Good Samaritan Hospital at ER. He's going to help narrate and explain to you what our paramedics are doing when they arrive on scene to treat a PNP patient. So guys, come on.
Hey, good morning, everyone. I'm Dr. Ben Sullivan. I'm actually a family physician, but I've been working in emergency medicine for about 7 or 8 years. So I strictly work in ERs now. I've been working here at Good Sam the better part of 4 or 5 years, I guess. So I've been working with these guys for quite a while. How many of you have actually taken basic life support, CPR, something like that? Anybody? Excellent, very good. So if I use a phrase or a term that you're not familiar with, please just ask. Sometimes these things that become very normal to us are foreign to everyone else. So as we said, now basically this is a 911 call goes out for someone who's a PNB, pulseless non-breathing. So we don't know if they collapsed at a restaurant or whatever the situation is, but that's what we've got. So EMS is called to the scene. I'm going to try to narrate and let you know exactly what they're doing. So we'll take from here. So these guys are just now arriving on scene.
Look, listen, and feel for a pulse. Check for any breathing. If no pulse, no breathing is found, instantly we're going to start the steps of CPR.
So basically, they go through the ABCs just like everyone has been taught: airway, breathing, circulation. First, if they're responsive, are they breathing? Do they have a pulse? The nice thing about having a 3-man crew is we can attend all these things simultaneously, not one at a time. So as you can see, we've got someone controlling the airway. We've assessed they don't have a pulse, so we're starting CPR. The third individual is now starting an IV line, so we can administer medications if need be, IV fluids, etc.
I'll just turn the monitor on. I hooked up the deep patches.
As most of you know, it's very important the first few minutes, or the early part of a code, for example, is the most important. If someone goes down, they don't have a pulse for 4 minutes, it's almost impossible to ever bring them back. So the earlier we can get someone on scene, the better off we are. I have worked in some facilities where we have basic ambulance services, not paramedic. And that's basically load and go. you know, they can't even start an IV. They basically load, it's just like a taxi almost. So they load up the patient and take off to the hospital. Here, we're actually bringing the emergency room to the patient. So
Everybody
early
clear?
intervention.
Stand clear, I'm clear, you're clear, shocking. Shock delivered, continue CPR.
Start CPR.
So at this point, you know, they've assessed, they can see the rhythm on the monitor, they've assessed that we've got a shockable rhythm. Sometimes we'll have shocks, sometimes we won't. In this case we did, so we shock, we continue with CPR. This goes along with everything that's taught by the American Heart Association. So we're getting an IV started.
IV is established.
IV is established. The paramedics have to make the decision in the field as to whether or not to continue working with the patient where they are, or should we just load and get to the nearest facility. In some cases, here in Merrill, most of the time our transport times are fairly short. In other locations, they can be 20 minutes, 40 minutes or longer. So it's nice to have these guys working out there. I feel a lot better having them than a basic or intermediate, because most of the time, by the time the patient gets to me, they're fixed, basically. In this case, we're establishing a definitive airway. Sometimes it's difficult to ventilate patients. So we actually put a tube down into the lungs, and then we can actually introduce oxygen much easier, much more efficiently that way.
Listen to the breath sounds.
Basically, this is a field mechanism of
Condensation in the tube.
All sounds are clear.
making sure the tube is in the right place, not too far down into the lung, so it's only aerating one lung. Sometimes you can intubate someone and actually put the tube into the esophagus. So by listening, you can actually hear the breath sounds when they're ventilating the patient. The thing is, we want to try to do all these things simultaneously. We want to try to continue with ventilations, continue with CPR, because that's the only thing that's pushing blood around the patient, as well as oxygen.
Secure in the airway.
Push analyze.
As many of you know,
Stand clear.
one round is used, compression should
Shock
do 2 minutes.
advised.
We analyze the rhythm, shock if needed, if not, continue with
Stand
CPR.
clear.
Stand clear. Push to shock.
Clear.
Yeah.
Shock delivered.
Start CPR.
Airway's clear.
The nice thing is, this is exactly the same thing that happens in the hospital setting. Fortunately for us, we have more people around, so we have a lot more help. I don't know if any of you have ever actually performed chest compressions on someone. You can tire very quickly. If you do that for 2 minutes, you're sweating. It's a lot of work, it really is.
Administering epinephrine.
So in this case, he's giving a drug, epinephrine or adrenaline, which helps to stimulate the heart, improve the contractility or the electrical activity of the heart also. Some of you may have noticed he's got a little mechanism here on our, what's called our ET tube, or endotracheal tube. And that's also to help check whether or not the tube is in the right place. It changes colors if carbon dioxide is being expelled from the lungs. If it's in the stomach, it won't do that. So we use multiple backups to try to make sure we're doing things the right way. How's our patient doing? Do we have any kind of rhythm at all? I wasn't
Still in
V-fib, okay. So in V-fib, I don't know if you know what that is. Basically, the heart is quivering. It's not actually contracting. It's just sitting there going like this. So it's not pumping blood. It's not moving oxygen through the tissues, the brain. And those are things you definitely have to have if you're going to survive.
Third round, analyzing rhythm. Stand clear.
Analyzing now. Stand clear.
Electrocution is prepared.
Shock advised.
Shock advised. Stand clear.
Stand clear. Push to shock.
Shock location, stand clear, I'm clear. Shock delivered.
Start CPR.
So
We did
according
get
to
a
the guys do good work. According to advanced cardiac life support, basically we do chest compressions for 2 minutes, we analyze the rhythm, we shock if indicated, if not, we do CPR. Basically we go either shock, medications, and CPR, so it's basically 2-minute cycles. So this is actually, this is about the way it goes routinely, I mean, in the facility or in the field. And as I said, early intervention is by far the best thing that you can do for these people. So it's nice that we've got these guys out there. If we don't get to them within 4 or 5 minutes, it's tough, it really is.
We do have a pulse pack. We're gonna prepare to transport the patient.
Excellent. So and these guys are constantly in contact with us. We are, as the physician working in the emergency department, I'm considered medical control. So if they have questions, concerns, if they have questions about medications, they pick up the radio or the telephone and call us. So there's a lot of communications back and forth.
How long would they keep doing that before they go to emergency?
That depends on, there's a lot of situational things, and these guys can probably tell you better than I can. But a lot of times, it kind of depends on, like I said, transport times. If it's gonna be a long transport, depends on how long the patient has been down. Now, in this case, they've gotten back to a regular rhythm, so the patient is now stable. So he's got a rhythm, he's got blood pressure, we're ventilating him. So he's stable at this point in time, so we need to get to the closest facility. Now, a lot of times these guys will bring a patient to me just like this, which makes me, I breathe a sigh of relief when I hear that they're doing well. And they'll hang around, and then they'll actually transport the patient down to the cardiologist down in Wausau from our facility. That's for the definitive care. So it just depends. I mean, sometimes we actually, if the patient has been down an unknown period of time, for example,
Push analyze.
they may end up having to call a code. They may end up quitting resuscitative efforts in the field. And there again, that's something they always communicate with us about.
That could depend if it's a medical situation or a traumatic situation. So sometimes car accident, gunshot wounds, sometimes depending upon the amount of blood loss, there is really sometimes nothing that we can do. So definitely try, but sometimes we have to make a decision if it's going to be to the patient's advantage to try to keep up with life-saving techniques.
There are many times too on a scene, if we have an unknown patient, unknown reason why they're down, there's multiple other medications that we can try. If a person's a diabetic and we don't know, well, we have sugar solution that we can try to give to the patient. If the patient has been down for a long period of time, we have another medication we can try to give to them. So there's times that, you know, if we don't get a response like this, where we get a pulse, a rhythm back to their heart and an actual perfusion rhythm, that we will try multiple other medications before we stop, you know, trying to revive the patient, or before we decide to contact medical control to let them know what we have, to see if they have any other ideas too. All the medications we carry on the ambulance are the exact same medications that they use in the ER room. You know, they do have a couple other ones, and we might have something different from them, but all the ones that we have for life-saving issues, we have right there with us. So instead of taking that time to transport with only 2 guys in the back of the ambulance and 1 guy driving, you know, we can maintain that person, but we're not able to do as much work. Whereas if we stay on scene with all 3 guys working on this patient, 1 controlling airway, 1 can do CPR, and then 1 person can figure out the medications that we're going to administer, or they can contact, you know, our ER physician like Dr. Sullivan and find out if he has an idea of what we should use before we decide to call a code and say the person is non-viable anymore. So I guess every time is different how long we stay on scene. If we do have a rhythm like this, we'll try to transport as quickly as possible to try to get them to better care for their heart condition or what might have caused it.
So are you able to do exactly what you're doing now in the ambulance? Is, I guess, my part is, or,
If we would have had this patient with no pulse, what you saw here was mainly, you know, we established an airway. We were able to breathe for the patient. We were able to keep the heart rate with our compressions. Well, that's 2 of our people right there. We wouldn't be able to do, I guess, the medication part, the stuff that, you know, quite a bit of it, I don't know, Dr. Sullivan, you might be able to talk a little bit more of it, but quite a bit of it, you know, a lot of it is trying to get that heart perfusing, you know, trying to get the blood circulating, trying to get the oxygen. That's a big part. but to try to get that heart to start again, you know, these medications have to be administered too. So in order for us to leave the scene, it would be very difficult to try to administer these medications while keeping that blood going. If you stop moving that blood by compressing that heart, well then that body, it takes another 30 seconds to actually, you know, before you can get that blood moving again, given good compressions, it'll take another 30 seconds to actually get the blood circulating again. You gotta start back over. If you're able to keep the compressions going the whole time and not stop, not take one guy away from it, it's, you know, it's more better for the patient's long-term outcome. And the same goes with breathing for the patient. You know, you keep oxygen going in and that blood circulating. So those two guys have to maintain that the entire time and keep that patient viable. And then the third guy would be for giving the medications until we think we've given as much as we can to transport into the ER or call it.
And this is one of a multitude of different scenarios you can have. And sometimes they'll pick up a patient that someone's having chest pain, and then they can turn into something like this very quickly. So it may be in the midst of a transport when this happens. So there's all kinds of things that can go on, definitely. But the thing I can stress, it's nice having all three of these guys there because they can drive and they can manage the airway and they can do chest compressions or administer medications en route. You know, getting to the hospital, we do have more hands. And the other thing I like is when these guys show up at the hospital, they don't drop them off and take off. They stay there and help out. As I said, doing chest compressions is tiring. Their effort, I mean, they come in and help us out all the time. They'll help start IVs if we need additional access. So it's great having paramedics around. You know, some hospitals have them hospital-based, so they work there all the time. We're not fortunate enough to have that. But
Are there always three of you, and one's the driver, or is there a driver?
No.
It depends on the call. If it's a traumatic injury, we'll send 3 personnel. If it's a cardiac arrest, 3 personnel. Respiratory, either distress or arrest, we'll send 3 personnel. If it's an unknown problem, unknown reason why the patient's down, or someone was just told to call 911, they don't know what the problem is, we'll send 3 personnel, just because we're not sure what we're gonna run into when we do arrive on scene.
A lot of times if we have a minor call, I would say, you know, it might not be minor to the person at the time, but if we have something, you know, if it's a known seizure with no trauma, you know, it's been known that they've had seizures before, or diabetic episode where they have a low blood sugar, you know, or if it's something where someone fell and, you know, broke finger or, you know, a wrist or possible just a small injury, we'll send 2 personnel to start out with that call. And then if it turns into something worse, we'll try to call for a 3rd. But I mean, you never know whether it's gonna be, you know, it might come in as a very simple call from what you could think or whatever. We'll send 2 people, and we have done it in the past too, where you call a 3rd person because you've gotten there and the person is unresponsive and their color is turning bad.
Are the designations to give medication and things like that, does everybody have that in the department, or EMT or whatever the titles are to do all this stuff?
with the paramedics, they are. Of course, as I was talking about with basics, for example, they can't give medications, they can't start IVs. So it depends on.
Paramedics then, or?
Not all of them, no. There's also intermediates, which they can start an IV and they can give limited medications. So paramedics are, I mean, that's the ultimate. And I think a lot of even smaller departments are trying to go to that. Eagle River, for example, they just switched over the last couple of years into a full paramedic outfit. They're hospital-based also. But they were, and some of their outlying services are still basics or intermediates. So the paramedics then will go out and intercept. So they'll go out and meet the other ambulance as they're coming in because they have a longer transport time. I can't stress enough that early intervention is the best thing for many things. Case of a stroke, we've got 3 hours from the time of onset of symptoms to get medications into that patient, which can potentially break up a clot that's causing it. So time is muscle, time is brain.
Biologicals, a lot.
more of a fireman when they're doing this kind of work?
Well, it's a lot tougher than you think. The equipment isn't light. That's the first thing. They handed me the equipment and I practically fell over. I don't know if you ever, when you were younger, got to pick up your father's chainsaw or anything like that. First time you do it, you're like, holy cow. Then you start doing the work and you're having issues and the machinery's getting heavier and everything. Oh, it's crazy. I have total respect for these guys. Total respect.
How's for in general, do you think it's a good experience for what they're showing you, or?
I would like to see, and I know it's kind of being thrown about as a public one, Fire Ops 101, basically. I think this is an excellent experience. Everyone should do it. Play firefighter for a day. That's what that's what I gotta say. Play firefighter for a day so you have respect for when they really come. But if they ever do a public one, I recommend everyone come out and do it.
Just wondering what your aspect is now after going through the scenarios you have been of firefighters and their duties that they have to do.
Oh, it's a lot more to do with personal safety than it is just putting the fire on. A lot of people don't remember that. The safety of the men and the equipment. And the equipment they have to have in order to go in and fight it. They have to work in teams. Buy all the good equipment you want in the world. You have to worry about the fireman's safety too. It's not just putting out the fires.
And also, what's your aspect of the whole event today?
It's good. It's good. It was well attended. Good cross section of people. A lot of government people. You have to make our budgets. It gives them a little more understanding of where the money's going.
We had one interview. He was saying he'd like to have more public opening, not just this sort of public view, it's more private and everything. But what would your aspects be about that? Have public viewing of this, like if they just had like you just signed up and people could come out, be a firefighter for a day.
Well, they can do that. That's kind of what this is too. But it's just, the more the public understands, the better. They can have a public day out here. Much the same as you'd have at the airport or any place else. Or even at the fire station. Bring them out here instead.
There you go.
Here they see the real stuff. Down there they just see the shiny red trucks.
All right. I'm just wondering, how do you feel today's events went?
Well, the events, I'm glad it's over, number one, because it's a lot of work that we put into this. We've been I think we started back in April planning for this. We had monthly meetings with departments from the area, Antigo, Wausau, Rhinelander, Weston. So we've been planning it for a while. There's a lot of behind the scenes work to get a one day event in. And I can't even tell you how many man hours were put into this. I guess the biggest thing, looking back or reflecting upon today, was the fact that there was no serious injuries. Anytime you have firefighters, and especially people who aren't even firefighters or students, come onto a fireground scene or a hazardous scene like we had them in today, there's a chance for injury. And we escaped here with very minor scrapes and scratches. So as far as today, it went well. I think there was people that understood and learned a lot about what firefighters do, and nobody got injured, so happy.
I know you were talking about in there before about weren't sure if you have future events, but if you were, any changes you could think of now that you'd probably...
I don't know for sure if there's any changes. Because of the fact of how well it went off, I guess one of the advantages we had was that we attended Fire Ops 101 in Marshfield, and we also attended and helped out in Madison. So we had some experience, and we saw what things went well for those groups, and we saw what things didn't go well. We tried to adjust. I'm sure after we get done here and look back upon things and put our heads together, we're going to find some things that we can improve upon. And also, I bet you that the participants will have some pretty good ideas for us. And with all that information put together, I'm sure if we do this again, there will be some changes, hopefully for the better.
So Josh, I was just wondering how you felt today went.
I thought today was really successful. We had over 45 participants from the Northcentral Wisconsin area. The weather cooperated for the most part, a little cool, but kept people moving, kept them warm and going on the different scenarios. So I think it went really well. I seemed to get a lot of positive comments on the success of the event.
And also, we heard before, we don't know what you're doing if you do future events or not, but if you were, Do you feel any changes you might make or something?
I think there's always things that you can critique and do better maybe for the next time. I know we spent a lot of time, we've been planning this event since April or March, so we put a lot of time into planning it, so we're pretty confident it would be successful. I can tell you we probably won't be doing it again next year, but maybe every other year or something like that. But we had some evaluations that we left with all the participants, so we're going to get a chance to review that. The different departments will review, let them get back to us as well too, to let us know maybe what went well that we should continue to do and what things maybe we can do better or do different next time.